Do you order or bill for drug assays to the Medicare program? If yes, your medical documentation must comply with Medicare policy guidelines to prevent claim denials. With a national focus on treating opioid use disorders, urine drug testing claims are common audit topics in Medicare claim review programs. Our goal is to help you understand proper coverage for your patient services and how you can support the medical necessity of these services with your documentation. So let's discuss the information you need to know for documenting and billing these services. We'll start by reviewing the basic coverage. Medicare covers urine drug testing for 3 categories of patients. The first category includes symptomatic patients, patients presenting with multiple drug ingestion, or patients with unreliable history. The second is patients being treated for substance abuse or dependence. And the last category is patients on chronic opioid therapy or COT. We'll look at each of these groups in more detail, starting with symptomatic patients, multiple drug ingestion, and/or patients with unreliable history. This group includes patients who present in a variety of medical settings with signs or symptoms of substance use toxicity. It's expected that these patients will be treated presumptively to stabilize them while awaiting rapid test results, followed by definitive testing to determine the cause of the presentation. The need for definitive testing is based on the rapid test findings, the patient's response to medical interventions, and their treatment plan. A presumptive urine drug test should be performed for patients who present in urgent care settings with any of the following: coma, altered mental status in the absence of a clinically defined toxic syndrome or toxidrome, severe or unexplained cardiovascular instability, unexplained metabolic or respiratory acidosis in the absence of a clinically defined toxic syndrome or toxidrome, seizures with an undetermined history, to provide antagonists to specific drug. Next, we'll look at patients being treated for substance abuse or dependence. These patients are in active treatment for substance use disorder or monitoring during phases of recovery. It's medically necessary and useful for physicians to provide testing during chemical dependency treatment to determine appropriate treatment and level of care decisions. The frequency of testing must match the stage of treatment or recovery, documented history, and the Diagnostic and Statistical Manual of Mental Disorders Diagnosis. Presumptive and definitive testing frequencies are determined based on the patient's number of consecutive days of abstinence. First, we'll look at presumptive testing frequencies. For patients with 0 to 90 consecutive days of abstinence, testing is expected at a frequency of 1 to 3 tests per week, with testing not exceeding 3 tests per week. Patients with greater than 90 consecutive days of abstinence, testing is expected at a frequency of 1 to 3 tests per month, with testing not exceeding 3 tests per month. Next, we'll look at definitive testing, which may be ordered when necessary based on the patient's substance use history and when results are needed for treatment decisions and clinical assessment. For patients with 0 to 30 consecutive days of abstinence, testing is expected at a frequency of 1 test per week, not to exceed that 1 test per week. For patients with 31 to 90 consecutive days of abstinence, testing is expected at a frequency of 1 to 3 tests per month, not to exceed 3 tests per month. And for patients with greater than 90 consecutive days of abstinence, testing is expected at a frequency of 1 to 3 tests per month, not to exceed 3 tests in 3 months. Our last group of patients is those under chronic opioid therapy. Patients under chronic opioid therapy may need monitoring for adherence, compliance, efficacy, patient safety, side effects, and drug-to-drug interaction. The testing frequency must be based on patient-specific criteria, including patient history, physical examination and previous laboratory findings, current treatment plan, prescribed medications, and the risk assessment plan. As I mentioned earlier, urine drug testing claims have been a common topic for review because of the national focus on opioid use disorders. We see similar error findings from each of the review contractors for these services. These error findings are consistently related to the medical necessity for the frequency of testing, the risk assessment documentation, and treatment based on the risk assessment. All of these errors relate back to the documentation showing the patient-specific criteria that resulted in the steps the clinician has taken for providing treatment and ordering testing. So, what can you do to prevent impacts to your claims processing and payment? Here are some recommendations. First, the medical documentation must be individualized for each patient. Address the specific diagnosis and the treatment for that patient based on their diagnosis and history. The documentation should also include the risk assessment tool you are using for that patient, as well as the risk level that provides the basis for the treatment plan. It's important to remember that the frequency of testing should coincide with this level of risk that you have documented. Finally, if that patient's risk level changes based on your assessment, document this change in the record to support the change in testing frequency. You can prevent claim denials by knowing the documentation and testing frequency requirements and keeping these errors in mind when providing services to your patients. Review Medicare's policy guidelines and certify your medical documentation supports your services being ordered and billed. We hope you learn more about ordering and billing drug assays. You can visit our website for more resources and to check out our other educational videos. Thanks for watching.